Thanks, Barb. I'm very pleased to have the opportunity to welcome and introduce Charmaine. Charmaine is our next speaker, and as Dr. Shoamanesh indicated, this is a great opportunity to hear from Charmaine and her expertise. Charmaine is an acute care nurse practitioner, and she's been specializing in neuroscience for over 30 years. She's been very instrumental in developing programs and has clinically worked within acute neuro rehab, stroke, neurosurgery, neuro-oncology, and neuroendovascular programs. And with her various colleagues, she has been very involved in collaborating in research on improving outcomes for subarachnoid hemorrhage patients and those with intracerebral hemorrhage. For all of those patient populations. And her passion is to help educate and support teams to learn about neurological conditions so they can understand and have comfort and confidence in managing them across the continuum. So it's very fitting with Charmaine's passion to have her join us today. And Charmaine, I'm going to turn it over to you to take us away for the rest of the afternoon.
Excellent, thanks. Can everybody hear me, I hope? One of the things that I wanted to, oh good, I'm getting the thumbs up from Rhonda, which is great. I know that someone can hear me. I just wanted to talk a lot about intracerebral hemorrhage. Right now I'm working in St. Peter's in the Rehab program, which is the slower stream program where we get band 4 patients. And so it's good to talk about intracerebral hemorrhage and get people's awareness more because ischemic has definitely had a lot of the highlight in the past. Okay. One second while I get my computer to. So I'm going to do a real case-based approach because I always find that it's good to apply this to the real patients. And we can talk about the differences. So I have 2 cases for sort of that midbrain intracerebral hemorrhage that happens because of hypertension. And then I have the lobar bleeds that happen because of cerebral amyloid angiopathy or other causes that Dr. Shoamanesh had referred to earlier. And because they're very 2 different entities in recovery, and I think it's important, oftentimes people just say, oh, they came in with a bleed or they came in with an ischemic stroke, but they don't understand where it was, and where it is has a lot to do with how they recover. So I want to review the content for each case. It's talking about the cause, the risk factors, sort of location and size, and those things do matter. Secondary prevention, some trajectory for recovery, and then common complications that happen or questions that happen during rehab. So the first 2 cases that we're going to talk about are intracerebral hemorrhages inside the midbrain related to hypertension. So these are deep midbrain strokes. So who is most susceptible to this? Well, people with hypertension, obviously. And this also includes those, they get very brittle vessels with poor contractility with hypertension. And these are especially known, and we're going to talk a little bit about obstructive sleep apnea because this is a big contributing factor that people have to pay attention to more besides lowering their salt and exercising and weight loss and taking the medications. Sleep apnea has a big component as well. There's an ethnic component of certain populations, the Asians, the people of African American culture background have a higher incidence of hypertension than the white Caucasian population does. People who are diabetic because the vessels get very brittle and more fragile. People with dyslipidemia, people with prior lacunar strokes, people with anticoagulation, and those who have smoking or cocaine use. Cocaine definitely causes a rise in pressure straight up into the middle of the brain. So what happens during intracerebral hemorrhages due to hypertension? So the blood pressure is shooting up through the top. They have these bleeds inside the brain tissue with or without extension into the ventricles. And so there's the bleed just into the middle of the brain versus those that goes into the ventricles have different outcomes. So the bleeds primarily happen in the basal ganglia, the putamen, the thalamus, and the internal capsule, and some small amounts happen in the pons and the brainstem. So why is this important to know? So if you imagine you have your carotids on either side of your neck, and the flow is going straight up, and hopefully my arrow works, right into the area where these are where your carotids come out on both sides. And they flow into these vessels that sort of give all the fluid or all the bathing the middle part of our brain with oxygen and blood. And with these are the reasons why, when you're thinking of why does hypertension happen in the middle of the brain, well, if it's coming straight up your carotids, it shoots right up into the middle of this brain. So here is your internal carotids where they meet here, and they shoot out all into this area through here. So I just wanted to talk a little bit about what does that hematoma look like deep inside the brain. So, and this is an important part for why people don't look the same when you have an ischemic stroke versus a hemorrhagic stroke. So going to the, I'm hoping my arrows are working. Where'd my arrow go? Here we are. So here is this hematoma deep inside the brain. And around this hematoma, we have this really mass edema. And this is sort of your penumbra, your area where you're trying to save or recruit this tissue. And then because there's so much disorganization happening in the brain, you have this mild hypoperfusion that happens all around this area. So when the bleed happens, it's not just the bleed itself, it's all of this area of salvageable tissue around here, as well as all of this area. And this is in the first 2 days. In the next 2 to 14 days, you'll see the hematoma clot is still looking about the same in size. So the body has not had time to get rid of this. And you still have this area of hypoperfusion, although less intense than it was in the first 48 hours. But you can still see that this whole area around this bleed is not getting a lot of, and you have low metabolism happening. So this area is not getting its normal amount of electrolytes, its normal amount of blood perfusion, and therefore impacts this area around the clot itself. And then when you look greater than 14 days, you'll see that the clot is gone, and you have some area still of metabolic decrease here, because that's where the residual stroke is. So when we're looking at size of stroke, if you look at the very first picture, you're going to see a very small stroke here. And then if that stroke expands at all, which we talked about expansion of the stroke, you're still generally talking about a smaller stroke compared to this large stroke. You already see the brain being shifted over to the right side. And as that stroke expands, and then it starts to be reabsorbed, you still have a larger section. So knowing how big the bleed is kind of an important thing to know, and how much that has, where are we along that trajectory of recovery. So in the first, 48, 72 hours, we obviously have the massive swelling. And then as you get past those 14 days, you have less swelling. You still have some hematoma that's resolving, and you're left with the residual thing. That's why patients with intracerebral hemorrhage don't follow the normal pathways like ischemic strokes, where you can get them into rehab on day 5, because oftentimes they're still dealing with all this edema and poor ability of the tissue to metabolize things. If you get into the ventricles, the outcomes can be worse, because not only are you impacting the tissue, you're impacting the ability of the brain to make and absorb its normal amount of CSF, which puts pressure inside the brain. Any pressure inside the brain, remember the cranium is a hard vault, it's a hard bone, and when you have more pressure in it, the less the tissues can function. This is sort of a representation, and I'll go back to this diagram later after I explain it, but I just want to get some idea. So if you imagine that these are this is the center of the brain right in here. You have your thalamus here, you have your internal capsule right through here, and you can see the motor fibers going through here. And then you have your putamen in the back here, as well as your head of your caudate. And these are your sensory fibers going up to your sensory pathways on the brain. This is your motor fibers, which also go up to the motor strip of the brain. And I really want to emphasize, this is where a lot of the hypertensive bleeds happen, through your basal ganglia area through here, which impacts the motor fibers running and your sensory fibers running. So in the basal ganglia, the pathways and the processing station between the cortex, which is the upper part of the brain, and the thalamus for motor control. So this has a lot to do with how we use and have the muscle movement that goes, the message goes from the brain down through to the muscles, comes through the basal ganglia. It helps us with motor learning, some higher executive functioning. So we wonder why some of these people have cognitive impairment in the end, is because the basal ganglia helps us connect past memories with current information, and it also helps us control our emotions. It does take input from our sensory sources. So if our eyes and our ears are sensing something, it helps us define where our movement should be. So sometimes we wonder why patients can't sense where their whole body is. It's not because they can't sense or feel their feet or their hands, it's that they can't have the proprioception input come in. The thalamus helps to convey sensory information. So one is motor, one is sensory, and it helps us integrate our motor responses. It helps us with our sleep-wake cycles, so we wonder why thalamic hemorrhages always have problems with being up all night and asleep all day. And it also has expressions of your emotions. Your internal capsule is located between your thalamus and your corpus striatum of your basal ganglia, and it has all your motor pathways that go from through the middle, like through the middle of the brain, and then go out to the different motor pathways along the motor strip of the brain that is right up through the top of your head. And this is really important because anything that affects the internal capsules can permanently impact motor recovery. And then the pons, which is very few patients have pons strokes, thank God, because they have all of our motor and sensory fibers, and patients only have eye movement, and so they can only talk with their eyes. And these are locked in patients, which is a horrible situation. So going back to this, just a reminder, as we go through our patients, I want us to think about the sensory versus the motor. Here's the sensory through here, through the thalamus, our motor fibers, the internal capsule, and then you'll see why when these patients have different outcomes. If you kind of know it's a basal ganglia stroke versus a thalamic stroke, you'll be able to help understand with your recovery. So this is a 56-year-old male with an intracerebral hemorrhage related to hypertension. He presents in May at 2 a.m. with a severe headache. And this is always the thing that is different between ischemic strokes and hemorrhagic strokes. If they come in with new deficits and they have a headache, one must always clue into the fact that this could be a bleed. They have right-sided dense hemiparesis. They have, their sensation is intact. He has aphasia and vomiting, and he has decreased LOC. So when you look at his CAT scan, let me just get my arrow, you see this bleed deep here in the brain in the basal ganglia. You also see this darkened area that's all through here, which shows mass edema, and this is already just within the short, few hours of his presentation from 2 a.m. till about 6 a.m. You can already see the edema. The other thing that you can see is in the back of the lateral ventricles, you see a bit of blood there. So this is a gentleman with an intracerebral hemorrhage, basal ganglia on the left side with an interventricular extension. So day 10, he doesn't make it to rehab because of, obviously, he's got to be monitored more closely because of his interventricular hemorrhage and risk for expansion. And he's had terrible blood pressure control issues, which he doesn't end up in rehab. But when he starts his initial journey in rehab on day 10, which is of course past that day 5 that normally ischemics do, he has no motor recovery whatsoever of his arm or leg. He's got myoclonic spasticity. And why would that be? Because he's got sensation intact. So the sensation from the arm and leg is firing off to the brain, but there's no motor response in return. So it's like a teeter-totter. One's firing off and the other one can't respond. So you get a lot of spasticity early on. He needs moderate assistance ×2. He's incontinent. He can understand, but he's got a lot of problems with expression. And remember that left side of the brain is involved with language, although he's not directly had an insult to his Broca or Wernicke, because things get coordinated and communicate through this area for the language centers. He's got good understanding, which is his Wernicke, but he's still got difficulties with expressing, which is a motor function. He's got poor tolerance, he's got dysphagia, and he's got a prior history of depression. So already on day 10, this is worsened for him already. So his complications affecting rehab. So this is kind of like, these patients tend to have a more up and down roller coaster of time because they have more incredibly larger deficits. So he vomits, and this is predominantly more when he lays flat. This is an early on risk for him. He's got interventricular blood, so he has more pressure in his head. He's more higher risk. He also has that right-sided facial weakness, which puts him at risk for not emptying. He vomits, he aspirates, and gets an aspiration pneumonia. He has that interventricular hemorrhage, which initially caused him to have decreasing level of consciousness. This is less of an issue in the rehab, but it definitely impacted his ability when he first started because he had to kind of recover from this before he could actually get into rehab mode. He also had a difficult problem with hyponatremia. It's not uncommon with patients who have a big brain insult, whether it's a traumatic head injury, whether it's a big bleed, whether it's any kind of major insult to the brain, which helps us regulate and tells our kidneys whether to save salt or not save salt. That problem happens and they get an SIADH, which then we have to get into correcting that because we know that low sodiums can decrease their level of alertness and also put them at high risk for seizures. He, because of his aspiration pneumonia, he was treated with antibiotics, and those antibiotics ended up giving him C. difficile, not just a mild version of this, but a quite resistant version of it. And he ended up spending 8 weeks sort of acutely ill, not being able to participate in rehab. He had the myoclonus with a spastic hemiparesis. As I said, he had sensation, but no movement. And that kind of triggered off all this spasticity and tightness, which then we have to work with to overcome because we don't want to lose range as he gets better control. He had poor nutrition to start with. He wasn't a gentleman who had good nutrition, but his nutrition became even worse. He was depressed, he didn't want to eat, he didn't like the food because initially he was on a modified diet, and he got overall general deconditioning. And we're going to talk about how poor nutrition leads to worsening outcomes. Because of his depression, that was also an indicator for low ability to have fatigue. They don't want to participate. They don't have the drive to move forward. And that in turn affects how we recover. As well, this gentleman had infected and abscessed teeth, which caused more delay because we needed to get his teeth pulled out for him. So at 6 months out, so we always know that intracerebral hemorrhages, and we'll show some stats on that in a bit, have a longer time recovering than people with an ischemic stroke. And this is a fairly significant, he's a very, you know how we rate by FIM, the intensity of the stroke. He's obviously in a band 4 patient group, so has a larger stroke with more deficits. At 6 months out, they begin to level off with what the ischemic strokes are. Even as early as 3 months, they can level off. He has the right arm spasticity, which is under good control, but his right arm still hasn't gained any recovery. And we'll talk about why that is in a bit. His right leg, he can lift it up off the bed, he can move it around, he still has weakness, more so in his dorsiflexion. His plantar flexion, he will automatically go into because of his spasticity and tone, and he'll automatically have his foot down, and we need to always try to maintain opposition on that and keep good range. His dysphagia is resolved, so he's on a normal diet and drinking. His depression is treated and stable, but he did miss about 8 weeks during that rehab period. And that was from day 10. He started in the acute rehab, the faster track one, and then he came over to the slower stream rehab about a month later. His current function at discharge, this is now, you know, quite a few weeks. His bed is min assist. He ambulates with a 2-wheeled walker with 1-person assistance at 60 feet. His wheelchair for unsupervised mobility. His stairs, he's a mod assist ×2. His language, he still has some difficulty with sequencing and naming, but he has good comprehension, and his dysarthria, slurred speech, gets worse when he fatigues. And he's on a normal texture diet with thin fluids. So this is his stroke post, his CAT scan, sorry, post his stroke. And you can see that this bleed has left all the tissue around that. That was the penumbra around the stroke, is much smaller now and is all resolved. And we have that residual stroke there. All the ventricle blood is gone and the ventricles are normal size. So that's case number 1, and we're going to compare that with case number 2. Same thing, it's a basal ganglia bleed. This is a 72-year-old gentleman who is right-handed, came in with an intracerebral hemorrhage in the basal ganglia and also into his interventricular. Just like the other gentleman had interventricular blood, but this is a much worse bleed. As you can see, we're not only just thinking of the lateral ventricles, throughout all of his ventricles, he's got a large amount of blood. So he presented in June with word-finding difficulties and a headache. And he didn't think much of it. He thought he was just tired. He went to bed. And the next morning, he had full dense right-sided hemiparesis. He was completely aphasic. And he came in with a Glasgow Coma scale of 8. So a much lower presentation than the other gentleman. And he has much more blood, and that's one of the reasons why his Glasgow Coma scale is much lower. On clinical presentation for rehab, he's now day 20 to day rehab versus day 10 of the other gentleman, because he had to get an external ventricular drain because of the amount of blood in his brain. He's right-sided hemiparesis. He's developing a little bit of tone in his left leg, but he has both sensory and motor deficits, which the other gentleman only had the motor deficits. He's got a flaccid right arm. He understands some simple comprehension. He has no verbalization. He had a feeding tube and progressed eventually by day 20 to a pureed with thickened fluids. And he had a significant facial droop, loss of sensation, a significant visual field cut. So his course was complicated by something similar to the other patient. He had aspiration pneumonia, and this is a common complication because these patients are often having a decreased level of consciousness early on, and they don't always attend to a task. What they can do maybe during the morning and lunch for eating, by supper time, they're so fatigued, they're at higher risk. This gentleman also developed bilateral pulmonary emboli, because, and we'll talk about this a little bit more about anticoagulation, because he had ended up developing DVTs post 3 months and ended up getting bilateral clots. He had hydrocephalus, which became chronic. It was just mild, and they decided not to go ahead and put a shunt in. But you've got to remember that when a person has a bleed inside the ventricles, we make CSF in our ventricles and we absorb it. When blood is broken down inside the ventricles, it gets rid of the liquid parts of the blood first, and then it leaves the solid parts behind. Those solid parts line the bases of the ventricles, and they prevent the ventricles from fully being able to absorb as much as it produces. So there's a mismatch down the road with chronic hydrocephalus where we're making more CSF, but we're not absorbing 100% of the same amount in a day, and you're left with a slightly larger ventricles. And for some, they're left with significantly larger ventricles that they end up requiring a shunt. He's got urinary tract infections. He had initially retention of urine and got some bladder infections, and then he ended up with urgency incontinence down the road. That's the normal consequence for some of these patients. Initially in the acute phase, they retain urine because that signal between the front of the brain where it tells us to go ahead and pee and the midbrain, the thalamus. The thalamus is the area that we learn when we're younger as children to control our bladder, whether to hold or not hold. And so if you have a thalamic injury, you tend to have a disconnect between your frontal lobes and your midbrain to say, I need to empty my bladder, and they tend to retain and have overflow incontinence. As those pathways regain themselves, they end up more often with urgency incontinence, and I'll talk a little bit more about that in a bit. He ended up having a norovirus. This was an unfortunate event requiring him to be on non-invasive ventilation. He got profoundly depressed, which is no surprise given this gentleman was extremely active, super fit guy. He had a PEG tube and eventually got to oral feeds. He had seizures, and he required 2 admissions to acute care, which he was 8 weeks out of acute care to acute care as well. So disability at 5 months for this gentleman is the right arm really has no improvement at all, just like the other gentleman. His right leg, he's able to move it. He's able to lift it up off the bed, but for very limited amounts of time. And he's got a lot of weakness in his foot and needs a foot drop splint. His aphasia, he still has a lot of impaired expression, but he has comprehension. And his dysphagia, he has some mild residual, just monitoring more when he's fatigued than anything. So his functional status is discharge is that he could comprehend. He had some single words expression. His cognition is and through functional observations is moderately impaired. He's a Sarah study with a min to mod sturdy pole. He's got some spastic tone in his right arm and wrist as he's getting some sensory input through that's reaching the brain, but he can't move it in return. So there's information pathways taking the feeling from the wrist and going up to the brain, but he can't relax it and move it himself. He's got wheelchair as his primary mobility. He's walking with the therapist with a quad cane, a moderate assist ×1, and he's still incontinent. This is his CAT scan, and you can see that this is a small stroke. So these scans look almost identical, but the second patient, has a much larger deficit, which has required him to go to long-term care living, although at a higher functional level than if he wouldn't have had rehab. This is his ventricles. So you can still see that his ventricles are quite large, but they're not at the capacity where we would put a shunt in. And he still has up in this area here, a bit of residual deficit that's in through his frontal lobe here, and you can see a bit of seeping of the CSF still remains in the tissues around that. That's some of the residual hydrocephalus. So why the difference in recovery? They're both left parietal basal ganglia, they're both basal ganglia bleeds, both with interventricular hemorrhage. Why the difference? Well, one is the degree of hydrocephalus. The second patient was on an anticoagulant. He was on a DOAC. He was on a apixaban related to a remote history of an unexplained DVT. And he remained on that apixaban because they could never explain why. He had a full workup for that, but he was a really active guy. And so because he was on that apixaban at the time of his bleed, he ended up having a larger bleed with a more extension, more edema, and a decreasing level of consciousness. And the literature will tell you that if you're on blood thinners, when you have a bleed in your brain, that this is going to create a larger bleed. If you have a lower GCS in the initial 72 hours, you have potential for worsening outcomes, just because the initial brain has overall decline in function. There's a lot of mass edema, and so there's a generalized injury or insult to the brain. The number of severe medical events during recovery or rehab can also impact recovery. Both of them got aspiration pneumonia, which is very common, but the other one went on to have a norovirus that required ventilation, as well as bilateral PEs, because after we stopped the DVT anticoagulation, given Thrombo's recommendations. He went on to develop a clot in his legs and went on to have bilateral PEs. This is not the common for most patients. Normally after 3 months and their current status, you can stop it. But for somebody with high risk that they could never determine the cause for his previous clot, he was one of the ones who unfortunately didn't follow our guidelines for when to remove the anticoagulation. One of the things that is common for both of them, if you impair the cortical spinal tracts, so if you impair it, because remember at the very beginning, I showed you the pathways of where the sensory and the motor tracts went through the middle of the brain. If you permanently impair those tracts from communicating from where the motor pathways are at the surface of the brain, through the middle of the brain and out to the arm and leg, if that becomes permanently lost, that's one of the biggest indicators for impairment for permanent impairment, is those loss of cortical spinal tracts. So if you lose the cortical spinal, you lose the movement. If you lose the spinal thalamic tracts, you lose the sensation. So our first case, he had his spinal thalamic tracts intact. He was able to sense, and that's what gave him all those tone. But the cortical spinal tracts were both lost for both of the patients in their arm. Age, does it have some bearing? Yes, it does. Well, the first gentleman was younger, in his late 50s. The next gentleman was in his early 70s. But the early 70s gentleman was a very high functioning athlete. He was incredible. He was a runner, all those things, and was in very fit shape. The other gentleman wasn't, he was thin, he wasn't morbidly obese, but his self-care and management of his hypertension was a big issue. So it put him at higher risk for burden because he had a lot of those microangiopathic changes in his scan. So what do we know about recovery? And this is some of the evidence. So this is this Scandinavian stroke scale for recovery. So this is very severe impairment, this is mild impairment, and this is ischemic versus hemorrhagic. And so the percentage of patients who have more problems associated with hemorrhagic stroke. So more patients had pulmonary emboli with intracerebral hemorrhage, more patients had seizures with intracerebral hemorrhage, and more patients had pneumonia. And we know that pulmonary emboli was statistically significant enough to really impair recovery. And so when you look at that second patient who had bilateral significant burden of pulmonary emboli, even though it wasn't in the initial acute phase, he certainly had more complications and a worsening outcome as a result of that. When you look at some more evidence around recovery, if you think about age being across this, at the top here of this slide, so from ages 40 to 100, and at the bottom, you still have the Scandinavian stroke scale for recovery, meaning worse outcomes over here. The solid line is your hemorrhagic stroke. We know that, oh, lost my arrow here. Where did it go? Oh, here we go. We know that people of younger age have a higher proportionate chance of recovery than people of older age. So when you get in your mid-70s or later, your recovery is not as great as if you were younger. We also know that most of our complications are early on. So we have a 4-fold increase in the first week of intracerebral hemorrhage, of death, oh, sorry, gotta go back up, of death or disability. And as you get out to the 24-week mark, this is decreased dramatically. So this first 24 weeks after a post-bleed is the highest chance for more morbidity and mortality. This goes into recovery curves for years, and this actually speaks to the difference between ischemic and hemorrhagic strokes. In ischemic strokes, which are this is a solid line here, and hemorrhagic strokes, this is talking about their percentage of good outcomes. See, the percentage of good outcomes at 7 days for ischemic strokes is quite low compared to, for hemorrhagic strokes compared to ischemic strokes. So here's your hemorrhagic strokes at this level down here, and the amount that actually that they can recover at that point is quite low compared to your ischemic. But at 3 months, remember, many of these patients are at 3 months or greater, up sort of in here at 6 months, they start to level off to look the same. So although patients in the beginning may look worse over those first 3 months, the amount of deficits that they're left with are still about the same. You'll see in years out though, if you get in the 10-year mark, the people with hemorrhagic strokes, and we can't really explain why they do worse in the long run here at 9 years out, but that might just be age-related factors, or this may also be related to people as they get older who have cerebral amyloid angiopathy, which I'll talk about in my next 2 cases, have higher risk for rebleeding then. So factors impacting rehab, and we want to talk about blood pressure, and this is a hot issue because there's not a lot of really good trials that tell us what to do about blood pressure in the rehab phase. As Dr. Shoamanesh referred to, we don't want to be providing therapy if their blood pressures are greater than 180 over 100, or their blood pressures are less than 90 and they're symptomatic. So some of these patients who are really high, they get a ton of meds in the acute care, and by the time they hit rehab and they start to level off and start eating and their hydration's better, we have to really watch to see that whether we need to pull back a little bit on that medication. We try to aim for working with them for blood pressures of less than 160 over 80 or 90. And we need to also check for orthostatic blood pressure drops, especially when they're in the gym. If they get it all dehydrated, or if they have some significant valvular disease, we need to make sure that they're not bottoming out when they get up. One of the things that we need to think about is if a person wakes up every morning with incredibly high blood pressure, we need to be thinking about, we need to be thinking about, do they have obstructive sleep apnea? And one of the bedside tools that can really help out with that is the acronym is STOP BANG. So STOP means you ask the patient or their family, do they snore? Do they have daytime somnolence where they could pass out and fall asleep in the middle of the afternoon? Has anybody ever observed them having pauses in their breathing? And do they have high blood pressure? So these are questions that are things that you discuss with the patient and or their family. And oftentimes the person that their spouse is able to tell about the observations of the snoring and the observed apnea. Then we look at them as clinicians and we say, what do we know about them that puts them at risk? Are they larger in size? Do they have a big neck? Are they over 50? And are they males? Those are the higher risk people that have a tendency towards having obstructive sleep apnea. When you have decreasing levels of oxygen happening at nighttime, the brain senses this. It sends signals through the baroreceptors to push up the blood pressure, tighten the vessels, right? And try to push the oxygenation up because the carbon dioxide levels are rising. And all of those things, if it's done night after night after night, cause rigid vessels that are at high risk for bleeding. And you've got to remember the very first case woke up with his bleed because he had high hypertension at nighttime. Other factors impacting rehab is dysphagia or aspiration. And one of the tools that the best practices uses for nurses at the bedside, we obviously have SLPs, which we incredibly value their input in monitoring and moving forward our patients' recommendations around what texture and what thickness of fluids. But the nurses also have to be trained in some basic assessment skills. These patients will fatigue, and what they can do sometimes at lunch and breakfast is different in the evenings. And we have to be able to have the assessment tools to determine, can they eat what they can eat in front of them? The stand tool is a very helpful tool for anyone working at the bedside or in the community, that you can assess whether the patient's able to eat what they're currently at. It helps us to look at pureed, which is a pudding or applesauce, as well as with water, and to see how they can manage it and look for signs of that. And if you want more information on that, it's best to go to Rhonda McNichol-Whiteman. She's on the line, and she is an expert on rolling this tool out. I think it's also important to understand that we need to reassess for risk for dysphagia when a patient has another ongoing illness that's occurring at the same time. So whenever a patient has a bladder infection, or they've been kept awake all night, or they have a chest infection, and or they've had a recent seizure, their likelihood of their swallowing changing at that time can happen. So remember, when the SLPs assess them, they assess them for that moment in time, but patients can change based on these other factors of their medical condition, which puts them at risk for aspiration. Oral care is really important. We have a ton of bacteria in our mouth, and we can microaspirate it, so it's really important to keep good oral care. And that 8 to 27% of all patients, even with the best SLP, will still silently aspirate. Diabetes, if your sugars are high, your sugars are low, none of these patients were diabetic, but many of these patients can be. And obviously, if your brain is getting flooded with high sugars, you're not going to be able to be as clear and able to attend and recover. Malnutrition is another key thing. Both of these patients struggled with food and oral intake. One of them was transitioning from enteral feeds. Another was upgrading from a pureed diet with thickened fluids, and all of them had problems with hydration. Dehydration is a big risk, and it leads to constipation.
Can we just pause?
20%.
Everyone just mute their lines. If you're not, there's some background noise. Sorry to interrupt you, Charmaine.
It's okay. 20% of all patients are malnourished during rehab, and it takes twice the energy. So the energy we think to move our arm and to move our leg takes double that amount of energy to do it after you've had a stroke, because that area, those muscles are working so hard to work. And so what we may think is a normal amount of food that they need, they actually, for some patients who are aggressively working in therapy, need more nutrition to be able to supplement what they need. And we know that poor malnutrition can lead to very much decreases in your recovery, which is shown in decreases in your Barthel Index. It increases your length of stay in hospital. It increases your risk for infections and skin ulcers, and poor response to physiotherapy. So keeping on top of nutrition and hydration are both key things that both of these patients struggle with, and are common issues in rehabilitation. Medical comorbidities impacting recovery, hydrocephalus. So for some patients, people say, well, how do I know whether they've developed a chronic hydrocephalus after they've had an acute interventricular hemorrhage? A lot of these patients will have morning headaches. They wake up with a pressure sensation after they've been laying flat. So whenever a patient who's had an interventricular bleed is laying flat and they have headaches every morning and they can't focus, they can't attend, they seem more off, you sit them up and their headaches get better. You need to think about, do I have to get a follow-up CAT scan to rule out that they haven't developed a chronic hydrocephalus? For people who've developed enough of a hydrocephalus that needs a shunt, it can be life-changing in terms of cognition, urinary control, and gait. Other secondary illnesses that impact our neurological function. So if you have any other kind of infection, I don't know how many times people will come to me and say, Mr. So-and-so looks worse today, and he has a bladder infection, or he has some other infection, but neurologically, they look very the same, as it's almost as if when they first came into the hospital. Their weakness is worse, they're more difficulty talking, and it's because our brain only has so much cognitive reserve. So if just think of yourself with a cold, and when you have a cold, you're not as clear thinking as when you don't have a cold. When you have a secondary infection on top of a brain that already has a stroke, they will look worse neurologically. So whenever we're looking at a patient that looks worse, we need to think, is it something going on outside of the head from the neck below, or is it something going on in the brain? And those are two key things that you always have to be on top of during the rehab recovery. Post-stroke depression, both of these patients had depression. It's extremely common. 23 to 40% of patients are affected with post-stroke depression. It actually gets worse over the first 2 years as they become more aware of the amount of deficits or disability that they have. Disability can cause reactive depressions, and it's been shown that left-sided strokes have highest depression in hospital because of their language impairments and their ability to communicate with people, whereas right-sided strokes have your highest depression in the community. And this is especially if you have had strokes in your frontal lobe. Why your frontal lobe? There's our personality, our short-term memory, our insight, our executive functioning. They can't even figure out why sometimes they're feeling sad, but just because that connection of the way we think in the front is not connecting with the rest of it can make you feel like you can't move forward. You don't have that initiative. You don't have that drive to get up and get going. Neurotransmitters such as serotonin also change after a stroke. So whenever you have an insult to the brain tissue, that neurotransmitter, which is the serotonin, drops in levels. And without some replacement with a serotonin replacement therapy, i.e. antidepressant replacement therapy, you can't have that drive to move forward. So how I always explain it to patients, especially males who are really against starting antidepressants, is you have to imagine that if we were low on a vitamin like B12, we would replace it so that we could get better chances for the nerves and the brain to recover. If we're low in serotonin after an insult and you're showing signs of depressive symptoms, which we'll go through the tools in a second, you need to think about replacing it in order to get your best chance to recover. And we know that SSRIs have been found to help in motor recovery, and that's why some patients automatically with bigger strokes are put on meds such as fluoxetine, which has been one of the drugs studied. There's many ways to assess whether their patient has depression. There's the geriatric depression score, there's the hospital anxiety and depression score, there's the patient health questionnaire with 9 questions, and then there's the stroke aphasic depression questionnaire, all which are listed there, and you can look those up in the evidence-based review for stroke rehab or get a hold of Rhonda, who has all that information. The next thing that really impacts stroke recovery, and this starts from the acute phase onwards, so spasticity management. So our first case had a lot of spasticity. Others often are flaccid at the beginning and get spasticity over time as the brain is trying to rework and get the neurons to connect again. And things that nurses and therapists need to be aware of is that when the spasticity gets unremarkably worse than before, is that we need to be thinking about what are the things going on that's impacting this spasticity. So if the tone is so rigid and the hand is worse than ever, or the foot is flexed way down and you can't get it back in its normal splint every day, what else is going on? Do they have some sort of infection going on? That will make it worse. Do they have severe constipation? That will make the tone worse throughout the legs. Do they have bladder retention? Remember, we spoke about how initially on you can get bladder retention and it overflows. And I'm here that, oh, well, they're incontinent, but do they have a distended bladder? Because remember, the bladder is a muscle. If it's distended, those nerves are firing off saying, I'm full, but the front of the brain isn't saying empty. So then it's sending off all these stimuli and it's making the tone worse. So always scan to see if they have a distended bladder greater than 300 mils. If they have pain anywhere, like, or their clothing's too tight, even an ingrown toenail on that foot can really make the spasticity worse. Skin ulcers make the general tone worse throughout because not only do you have the pain receptors from the skin, you have breakdown, you have a potential infection, all of those things make spasticity worse. If you lose the range in the limb early on and you don't look at corrective methods, it's hard to use that limb more functionally down the road because you're trying to overcome that tone and range. Anticoagulation and DVT and PE prevention are another big thing that can happen after these strokes. You have question is what to do about anticoagulation. When they first have a bleed, we look at using non-medication treatments for DVT prevention, which is such as moon boots, and there's some evidence that The evidence around the TEDs up to the knees is that it doesn't work all that great. For higher compression up to the legs, it can work good, but the moon boots, the external compression on the calves is probably the best evidence for prevention of DVT. Obviously that and mobilizing them. At 4 to 8 weeks, you can consider starting the DVT prophylaxis, and you need to monitor. And as Dr. Shoamanesh says, if they need to be back on an aspirin, as long as their clot is stable, you can look at starting that as early as after 7 days. How long should the treatment be on? And I've consulted my thrombo experts here because the evidence is somewhat weak about what to do about this. It's usually around 3 months, and then you have to look at other factors that affect it. So for our second patient, he had an unprovoked DVT prior to him ever having his stroke. Even though the thrombosis doctors said at 4 months, let's stop it, he ended up developing another DVT and bilateral PE. So anybody with an anticoagulation problem from before is at higher risk still of developing a DVT after 3 months. If they've been recently ill with a new infection, obviously the inflammatory markers are throughout the blood. If they have a sepsis of any kind, they're going to be at higher risk for developing DVT, even though it's 3 months out. So you have to look at the patient as well as look at the time. If they were normally starting to mobilize and then suddenly they're not because they're sick, you may have to think about, do I need to temporize something during that rehab phase? Obviously, we connect with our therapy partners. How much are they recovering? How much are they moving? Is it consistent? All of those things have to be played into the equation of when to stop. Incontinence. So our first patient developed improvement of incontinence and was able to manage. The other patient couldn't. And some of that has to do with both the motor and sensory pathways being intact in sort of that midbrain section again. 20 to 79% of all patients have problems with incontinence in the acute phase. That goes down to around 14 to 19% after 6 months. So this can improve, but if you do have persistent incontinence, this increases your risk for being institutionalized, because a lot of patients, they might get a bit more functional, but their families can't cope with all this incontinence issues at home. So there's different types of incontinence, and I can't go into any great depth of this. The first 3 are usually the kind that we see in rehab. So urinary retention with overflow usually happens a little bit more in the acute phase, where the patients can't get the signal from a full bladder, which goes up through your spinal thalamic tracts to your thalamus. Thalamus is in the midbrain. If you have a stroke there, remember the message is not getting there, and can't send a message to the front part of the brain saying, I need to pee, so they retain. We have to do intermittent catheterizations, otherwise they overflow, the bladder gets distended, it flows up into the kidneys, and they get hydronephrosis and kidney infections. A lot of patients, and that's why thalamic strokes can tend to have that sort of permanent problem more so than the other parts of the midbrain. Urgency incontinence is predominantly the most that patients are left with. That means as soon as, if you imagine the bladder as a circular sort of oval object, and if one side of the body is weak and the other side of the body is working, one side of the bladder is functioning to expand, contract, while the other side is just kind of hanging out and not sure what to do. So they get a little bit of urine in that bladder, and the one side that's weak, say they're right-sided weakness, the right side of their bladder will be weak, and they can't contract and formulate a good emptying and a good expansion. So they have to pee all the time, which is a really difficult thing for the frontline nursing staff who are working with these patients. They get a small amount, they have to pee. They get a small amount, they have to pee. And they're feeling like they have to go all the time. The functional incontinence has to do with their ability to actually get to the bathroom and our ability to get them to the bathroom within a timely manner. So stress incontinence has to do more so for women after having children, for men after having prostate surgery. So they might have a prior history of stress incontinence, but then now you add on it urgency. and you have a weak set of pelvic muscles and you're now having to pee quickly and in a hurry, it's hard for them to maintain continence. So that's sort of the intracerebral hemorrhage midbrain look. And I'm not sure whether I'm supposed to stop at this time for a break.
Excellent information, Charmaine. There is so much here. It was really informative to me, and I'm sure others. We're running about 25 minutes behind, so I'm wondering, we were planning to go into a breakout right now, so I'm wondering if we want to abbreviate that or if we want to just do the second case and have one breakout. What do you think?
I'm happy to do the second half, and then I think the questions might come together for the whole thing at the end, if everybody else is okay with that.
Yep, we're good. Yeah,
okay.
Okay.
Yeah, we can.
So the beauty of having your camera off on Zoom, if you have to have a stretch break.
Oh yeah, please get up and stretch.
But keep listening.
Yeah, you guys can move around and I can't see any of you, so.
So Charmaine will continue with our second case study and we'll do a breakout after that.
So I want to talk then now about having bleeds in the lobes. And I know that Dr. Shoamanesh showed the difference between a bleed in the middle of the brain and a bleed in the lobes. And I want to talk a little bit about cerebral amyloid angiopathy, because this happens more in our elderly population. And as we're getting more aging people, we need to be very familiar with what this is. So Dr. Shoamanesh didn't go into a lot of detail about this, but I think it's important because a lot of the frontline staff know blood pressure. We can think about it. We learn it from the very early times of our career, but we don't really learn a lot about cerebral amyloid angiopathy. And these are deposits of beta amyloid in the walls of the cerebral arteries, the arterioles, the capillaries, and the leptomeningeal and cortical veins. So remember in my early picture, I showed all those veins and these arteries, sorry, in the middle of the brain. These are ones out in the lobes. So as these amyloid plaques deposit out towards the surface of the brain more than deep in the middle of the brain, or along the surfaces of the meninges of the brain. They develop little microaneurysms, have little fibroid necrotic areas, and we know that CAA is associated with Alzheimer's disease. We also know that some versions of CAA, not all, are genetic in origin from the Danish or Icelandic background, and they have a higher bleeding risk. So risk factors associated with having cerebral amyloid angiopathy or CAA is that it's older population, greater than 65. It hits males and females equally. They have a 5-fold hazard risk ratio of an intracerebral hemorrhage. So as you get more and more of these amyloid plaques build up in your brain, and remember he showed that one picture of an MRI where he showed that iron staining at the top of the sulci. He also showed all those little micro dots out in the periphery of the brain. Those are all related to cerebral amyloid angiopathy. Those are those little fibrotic lesions or those little areas of high risk homocysteine where they're at high risk for bleeding. The in-hospital mortality for patients with CAA is 24% because they can bleed, and oftentimes older people are all, I don't know too many older people who aren't on an aspirin, so they're already on something. If not, they're on another form of anticoagulant. And at 6 months, it can be as high as 32% if they have a rebleed. The lobar bleeds are higher in the temporal lobes, so the sides above our ears, and on the occipital lobes in the back. They have a 10% risk of reoccurrence annually. So every year you have a 10% risk of having another intracerebral hemorrhage. In the hypertensive group, that's less of a risk if you're controlling all your risk factors. Whereas in these patient population, you can't control all these risk factors because these are pathological things that are developed in the arteries themselves. And the prognosis of when you have these bleeds is based on where you have the bleed, how much it leaves you impairment, how big the bleed is, do you have loss of consciousness, or do you seize? So what do you do with anticoagulants and these patients with cerebral amyloid angiopathy? So they have a higher risk when you have this cerebral amyloid angiopathy. So when you have these amyloid plaques throughout the periphery of the brain, you have a higher risk for bleeding. If you're on warfarin, it's worse than if you were on a DOAC. So that's what Dr. Shoamanesh also talked about, that if they're going to restart something, they start a DOAC like a Pixaban or Rivaroxaban or something like that, because there's a higher risk with warfarin of having a worse bleeding. Before you even consider starting anticoagulation again with these patients, you obviously look for controlling the common things. If they have high blood pressure, you obviously want to control that, but many of these patients may not have that. You also consult your thrombosis doctors. You look at them going into research trials, which the Enrich trial for AFib is what Dr. Shoamanesh was talking about. So if you're wanting to put them back on an anticoagulant because they have atrial fibrillation, enroll them in a trial, because we need to find the answer to this. Some people do MRIs to look at the burden of the amount of amyloid plaques to help them. So Dr. Shoamanesh showed a great picture at the end of his talk when we were doing the questionnaire of those micro dots throughout the surface of the brain, or those amyloid heme changes in the sulci of the brain. If you have a high burden of that, that will obviously impact. Antiplatelets, oftentimes if you have AFib or one of those components, can be started sooner after 1 week. So let's walk through some cases with this. And you'll see that these people do differently than the people with the hypertensive midbrain bleeds. So this is a parietal lobe bleed on a 68-year-old gentleman. In October, he had a headache for 1 day. And remember, headache means more likely a bleeding stroke versus a ischemic stroke. Headache for 1 day with new onset of dysarthria. He then developed dense right hemiparesis with worsening dysarthria and decreasing level of consciousness. He had had a previous TIA on the opposite side of his brain and had a right carotid endarterectomy done in May. And so now, several months later, he's having a bleed on the opposite side of his brain. This is his initial scans, and as you can see, his brain's pretty tight. He's lost all of his sulci here. His ventricles are, his brain is midline. He has a fairly significant bleed, and you can see these darkened areas, which are high risk for expansion of his bleed. The key area that I think I want to pay attention to is if these bleeds happen along a motor strip or a sensory strip. So his bleed is right about in here. And remember, we have all of our motor functions here and all of our sensory functions here, and then how these all coordinate occurs through here. Oh. So on clinical, sorry, I'm just gonna make sure. On clinical presentation, he had the right-sided facial weakness and some impairment of his shoulder. He had the dysarthria. Sorry, he had right arm and hand at rehab on day 15 post his bleed. He had some movement of his right arm and leg, right hand, sorry, and arm, but his leg was completely flaccid. And he had right-sided neglect. So why does he have right-sided neglect? And why does he have weakness more so in his leg than his arm? So if you look at his scan, looking from your front of your face backwards, this picture is taken. This is the top of your head. Sorry, this is the top of your head. Let me get my arrow back. Oh. There's my arrow. So this is the top of the head. This is the bottom. This is the left. This is the right for people who don't read scans often. So this is the left side. You'll see this big hemorrhage in here with these areas that show that there's at high risk for rebleeding initially. And you see that he's mostly up at the top here. And when you look at the motor strip, you'll see that if this is where the bleed is, right in here, this is where your foot, your ankle, your hip, your trunk is, all in the area. So not having any function of his leg is not surprising. You can see his hand is here, and his face is down here. So why he improves so much in this areas first is as the edema went down and he got the function back, he ended up having residual of what was left for where the actual hematoma was. So at 42 days, his current function is, and he's still a patient in rehab, he's got very slight weakness in his right wrist and fingers. His arm is pretty much completely recovered, so is his face. He's got right leg, his hip extension is great. He's able to lift it up anti-gravity and pull it up off the bed and leave it there. Not quite mild weakness, but pretty good. And his foot is starting to get recovery. So how come he's getting recovery compared to the patients we talked about earlier? Well, we're 42 days out. We've got a lot of the blood gone. We're no longer impacting along that. Remember, the motor pathways in the middle of the brain are intact. We're now talking about just the motor strip of function further out in the brain, in the lobes. He's now got sensation. He's able to sit, to stand on his own, just with supervision. He's using a four-wheeled walker with one person assistance. He's got some ankle brace around his foot to help with mobility with the therapist. He's a min to mod to dressing. Mostly his lower body is more work than his upper body he can do on his own. And he's continent. His only complications in the hospital so far were right flank pain. He was passing some stones and constipation. So when you compare that to the complications versus the ones with the interventricular hemorrhage and the midbrain hypertensive bleeds, he has less risk for running into problems than the people who had the deep midbrain interventricular bleeds. The only thing that needs to be done is cerebral amyloid angiopathy is a diagnosis of exclusion. Many things can help us on the MRI and CAT scan to say this is probably the thing, but unless you're biopsying it or at autopsy, you can see the actual diagnosis. We always need, once the blood is resolved at 3 months for sure, to do follow-up imaging to rule out that we don't have some other underlying vascular abnormality like an AVM or a fistula or some underlying lesion, because we need to make sure, because this mostly happens in people who are greater than 70. He's just below that mark, so we always like to make sure we're not missing anything that could be treated. The second case of intracerebral hemorrhage is a 74-year-old female who came in once again with a parietal lobe. It's supposed to be left parietal lobe, sorry. She has right-sided weakness, my error in the slides. July 20th, she presented with a headache and slight right-sided weakness. Her CT, I'll show you in a minute, shows a 3 to 4 centimeter hemorrhage in the left parietal region. She has a history of atrial fib on warfarin. Remember, the difference between anticoagulation does make a difference. She was referred to neurosurgery as they were worried that she had bleeding into a tumor because sometimes tumors can bleed, and she had a past history of cancer, so they were worried. She had a renal cancer and that kidney was removed, so they were worried about tumor, and so they sent her into neurosurgery and said, could this be a tumor inside this blood? She went on to have a brain biopsy, and the brain biopsy showed that she had cerebral amyloid angiopathy, so hers was confirmed. Here's her CAT scan. Here's the initial bleed. You can see on this MRI imaging, which looks slightly different than the CAT scan, all this enhanced area around here is the edema. As the blood clot resolves, you see this is the residual amount of stroke left. And then she went into neurosurgery and had a part of that clot removed. At 90 days post-stroke, this is a 3-month indicator that we talked about in some of our studies, she has no motor or sensory deficits. She surprisingly doesn't have any sensory deficits, which, because I guess she's just back behind the sensory strip, but she has no motor deficits. Her memory still is a bit impaired, and we always like to follow our MOCAs, because remember, this disease is associated with cognitive decline. And because of the amount of amyloid plaques throughout the brain, it doesn't just affect one area of the brain, it affects all of it. And it's more associated with Alzheimer's disease. She is fully functional with her BDLs, and her only IADLs that she hasn't gone back to doing is driving. She's currently enrolled in the Enrich AFib trial of aspirin versus endoxapan, and she's actually been enrolled, armed into the endoxapan group. So she's actually been put on a DOAC even though she has cerebral amyloid angiopathy, with the goals of hoping to find the answer of whether we can put people on full anticoagulation to prevent ischemic strokes when they have atrial fibrillation, but a bleed. So this mechanism of recovery, this was shared by Dr. Shoamanesh earlier. So when we looked at this, we have the actual hemorrhage and we want to prevent the hematoma expansion. We have to remember that we have the actual bleed, which causes the ischemia. We have the mass effect, the increased intracranial pressure, any herniation, especially if they have interventricular blood. We have this blood barrier breakdown in the brain, which then brings in all these inflammatory markers, which then causes our end neuronal damage. So when we look at our lobar intracerebral hemorrhages and why we have different outcomes between the two patients with lobar bleeds and compared to the patients with intracerebral hemorrhages in the midbrain, is that once the hematoma and edema is resolved, around 14 to 20 days, you'll see remarkable changes in their function. And so initially, when they go, they don't meet those 5 to 7 days that they're going to recover and do really well in therapy. And you're thinking, well, they're missing that initial time. But what you want to do is prevent them from running into any complications during that time. And as their blood resolves, they start to get more and more recovery and more motor recovery in both the arm and the leg than what they do when they end up impairing that cortical spinal tracts and through the midbrain strokes. How well they do depends on the size of the bleed and where it's located. Both of these patients had blood in the same areas of the brain, but the one person had a much smaller amount of blood than the other person, and there was much more or less shift. So when the brain shifts and moves around, it takes more of an impact on recovery. Plus, the first patient was only at 42 days of recovery, and this other patient was at 90, so he still has more time to recover in that first 3-month interval. When you look at functional recoveries for intracerebral hemorrhages, living at home at 3 months, and this is your modified Rankin score, at 7 days, very few people are going to be living at home. They're going to all be having quite a bit of disability. At 3 months, we've got, close to 60% of these people will be living at home. And by 12 months down the road, we'll get a smaller proportion of those patients at home. But they still have a fair amount that are left with disability. And this is clumping together both of the cerebral amyloid angiopathy patients with the middle brain patients. So some of them are still going to have permanent disability. So when you look at lobar bleed recovery, if you start off with a low FIM of less than 40, which is these band 4 stroke patients, in the first 3 to 5 days, they say that this can help predict what your outcome will be. And that might be the case with ischemic strokes, but it's harder with the hemorrhagic group because it takes us longer to get over that bleed and the surrounding edema and that poor metabolism and that amount of secondary ischemic things that are going on to really get a clearer picture. So that has to be delayed usually a bit longer so we don't give up on these patients too soon. If you have cerebral amyloid angiopathy, you're bleeding in the lobes of the brain versus the middle of the brain, you have predominantly more distal bleeds, so close to the surface of the brain. They have less mass effect, which doesn't play on some of the key structures of the brain, and they can compensate using healthy brain around it. So when you think about both of our patients were parietal lobe bleeds. If we have a right parietal lobe bleed, we get more neglect than if you have a left parietal lobe bleed because the right parietal lobe will help compensate for the left. So these patients can get over that neglect syndrome where they can't attend to one side of their body much quicker because the other parts of the brain will try and help. And that's why knowing where your bleed is and knowing what you have to work with are key things in helping the intracerebral hemorrhage patients. That cortical connectivity, and that I referred to, so that's meaning that connection between the motor strip and the middle part of the brain, is some of your best indicators for recovery. And that neural imaging, we have functional MRIs and all that, have shown that there is compensation happening between one lobe and another to try and help each other as the neurons try to regrow or have neuroplasticity to help out with function. So that's why they can do lobar bleeds, because they have that plasticity and that neural recovery to try and get more function back. In our two cases, I referred to the left parietal bleed versus the right parietal bleed. These were both left parietal bleeds. They have left parietal helps us with our arousal and our attention, so they don't pay attention, they don't focus, they don't attend to their right visual stimuli. But the right parietal bleeds control all of our sensory awareness for both sides of our brain. So if you have a left parietal, you'll be able to compensate with your right side of your parietal lobe. Whereas if you knock out your right parietal lobe, it leaves you fairly impaired from a neglect point of view. So what are the key learning points from all four of these cases? Just to go through those, and then we can have time for some discussion. So intracerebral hemorrhage versus ischemic. We have delayed ability to start recovery due to the hematoma and edema, which I've showed you on these cases. Plus or minus medical complications that has statistically been shown to worsen their outcome. So if you get a PE, you're for sure going to have a worse outcome. If you get pneumonias and seizures, that's going to slow you down, but if they're well controlled and maintained and you manage the dysphagia, they can still continue to improve, but it will delay their recovery. If you have an interventricular hemorrhage, you have to follow for chronically them getting some hydrocephalus, which clinically the nurse will see if they wake up with headaches in the morning that are pressure. If you have decreased level of consciousness at time of admission, you for sure will have, your brain has been more disorganized and there's been pressure on more key structures of your brain. That will impact your ability to recover. If your hypertension related stroke bleed in your brain, you have a higher risk for more permanent motor deficits due to a loss of the cortical spinal connections of the midbrain. Remember, everything runs through that basal ganglia, the internal capsule, and if you knock off one of those pathways, even if the connection is intact to the rest of the lobe, there's no communication going through. Lobar bleeds have the options for compensating with surrounding lobes, i.e., if you have one part of your lobe, the other side parts of the lobe and the opposite side of the brain will try and compensate, versus in the middle of the brain. Cerebral amyloid angiopathy is usually diagnosed by autopsy or brain biopsy for sure, but there is some radiographic findings. They're more distal out in the surfaces of the brain and in older adults, and you need to rule out other causes. If you have cerebral amyloid angiopathy, you have a 10% annual risk for rebleeding versus those of hypertensive bleeds, because you can control their hypertension and you take away all the risk factors for that, including treating their obstructive sleep apnea. They have less risk for rebleeding. Prevention strategies for all medical complications need to be in place. So DVT prophylaxis, monitoring for urinary retention, maintaining their healthy skin so they don't increase having ulcers and having increased spasticity or pain. Those are all key things for improving recovery. We need to monitor and or treat for complications. So we have to expect that the intracerebral hemorrhages may have more complications than some of the, and that's one of the reasons why their function on those graphs is lower initially than the ischemic strokes, is because they will have more complications in that early phase. And so you have to treat DVTs, monitor for them, obviously treat PEs, which is a challenge when you have a bleed in your head to put them on full anticoagulation. Treat aspiration pneumonias and monitor and treat sepsis. The highest risk for death is in the first few weeks after a bleed. The intracerebral hemorrhage may be delayed in its ability to participate in rehab, but at 3 months, they match the outcomes of ischemic strokes. So we shouldn't give up on them early on. We need to monitor and treat post-stroke depression. Post-stroke depression has a significant impact on recovery, and so we need to be using the tools and assessments, both for the aphasic and non-aphasic patients, to help get on the treatment and recognize that our serotonin levels drop after a stroke. So especially devastatingly large strokes, they need that replacement to help with motor and recovery, as well as their mental recovery. Malnutrition is a poor outcome, especially dehydration. Treat obstructive sleep apnea. Manage all the things related to spasticity, including their range of motion, their splints. But if they get worsening tone, look for key things such as, are they in pain? Is their clothes too tight? All of those things that are common nursing things that we need to watch for. Incontinence, they start off as overflow, a lot of them, but they end up working to urgency incontinence, most patients, except for some of the thalamic ones. And we need to constantly keep in tact of trying to deal with their urgency incontinence and expect that that's going to impact how well they do and if they get home. Hypertension strokes need to assess causes and treat for further prevention of further strokes, as they can normally go back on their anticoagulations if you're treating their cause. And your BP in rehab may fluctuate either too low, because sometimes they overshoot in the acute care. You know how Dr. Shoamanesh says they go up, up, up because they're in monitored settings. Well, sometimes they level out and we find out in rehab that they're actually running too low. So we need to check in therapy that they're not dropping their blood pressures, and also make sure that they're not dehydrated. There's no clear evidence on what to stop them from doing therapy, but obviously we'd like to keep them around the 160 mark or less. If they're in the 180s over 100, going to therapy can be actually at higher risk for having more complications to their heart and their brain. CAA and causes lobar strokes have no prevention strategies. So no statins, unless they have hypertension, no treating hypertension, doing any of that's going to stop them from rebleeding. It has to do with what's going on to the vessels themselves. That anticoagulations for patients with CAA is normally not restarted unless they have high risk, like they have a valve or they have atrial fib. And there's studies underway to look for what to do about that. And that stroke-specific rehab, when they compared that to slow stream or general rehab, has better outcomes for people who are doing these slow stream recoveries with these big bleeds, because people are more focused on those stroke-based and have the knowledge to know that the stroke-based things to look for in their recovery. There. I guess we can go to our breakout session and questions.